Hey, welcome to the show. Today we have an interesting, topic, but I wanted to go over a pretty bad infection that I helped treat a while back. And it's interesting the fact that it started from a simple toothache and it progressed slow at first and then it got really bad really quick. And so we're going to go over it a little bit today is this case and kind of the twists and turns that it took for this patient and how we eventually got better, but it took a while. So let's get into it.
Buttermilk biscuits, here we go.
Sift the flour, roll the dough. All right, let me get rid of that shit.
That's better. I forgot that was on. Sorry. Yeah, so let's get into it. Toothache. It's pretty common. I'm an oral surgeon. Okay, I see people with bad teeth, with good teeth. Most every day, I'm going to see somebody in my office that's complaining of pain. That's why they're sent to us generally, right? Or for preventative, for wisdom teeth, things like that. But pain, even in the dental office, is pretty common. So everyone with pain is not going to have this happen to them. I've seen thousands of x-rays over the years. And when you look at your own x-ray or your family member's x-ray, or if you're a dentist or surgeon or whatever, you're going to see people's x-rays with little lesions at the end of the teeth, meaning little dark areas on the x-ray at the end of the roots, granulomas, little infections, things like that. If you've had a root canal, those are pretty common. Even after root canals, a lot of times they can persist. It doesn't mean you're going to end up like this patient. However, when clinically things are changing, you got to be able to recognize if it's happening to you, your wife, your son, or if you're the provider, taking care of someone. You should be able to recognize in your head, like, what's happening. Okay, I tried something, it's not working. What do I need to do? What's my backup? That sort of thing. So what I'm trying to get through in today's talk is kind of recognizing those things and then taking you down the path of an infection that kind of went bad slowly and then really quickly. And so let's get into that. So as most of us know, we have ChatGPT or whatever it is. Everything is available to most anyone as far as information goes. However, experience is still, that's why there's real people doctors, because of the experience and kind of like looking at someone and just determining how sick they are is actually kind of a skill. And so in my residency program, I did a couple of years of general surgery. And it's interesting because when you're called to the ER, as a general surgery resident or any resident generally on that service, you get to understand, looking at patients a lot of times, who's actually kind of sick or sicker just by the eyeball test. And it's kind of weird, but it is definitely a thing. And so you kind of get used to that, especially for ER physicians. I'm sure they have that pretty fine-tuned for the most part. So what I'm trying to do in this case, again, is just kind of go over my criteria, kind of what I saw, plus or minus what other providers may have not have seen or have seen. So toothaches, it's well known. They've had intraoral bacteria commensal to the mouth, found in brain abscesses. They've cultured them from lungs, from various parts of the heart. So bacteria can travel, right? So people with little tooth infections, so they're at risk, small, but not zero, for that infection traveling. And so it's a good idea generally to get them treated. So bacteremias are a real thing, right? So toothaches, they can go through fascial spaces. What that means is for if you're not a dental professional or whatever, if you have a toothache and you get a little infection, most of the time it's contained within the bone. When it gets out of that space, either through a fistula, like a little pimple on your gums, that's draining. That's usually not as bad. And it's not as painful usually because it's draining. Sometimes it gets beyond that. It gets to the vestibule. And from there, it can get to the cheek. That's the buccal space. If it's an upper tooth, sometimes it can get to the canine space, under the eye, side of the nose, upper lip, right? From that space, it can go to the temporal space. It can go internally to the lateral space and cause a breathing issue, right? It can track down into the lungs and cause mediastinitis. So not only that, bacteria in the bloodstream can travel remotely into the lung, to the brain. And so that's kind of worst case scenarios, even to the orbit, from the orbit to the brain. So these have all been reported, right? So Odontogenic infections can cause blindness. In this case, it almost, could have. And I'll go over that as well. And obviously brain abscesses, things like that. I've been performing full arch dental implant surgery since 2012. I started back then with Nobel implants, and I continue to use them today. Getting consistent results over time and seeing these restorations in function over that length of time has basically strengthened my use of the product. There's over 100 implant systems out there. I just choose the one that's been the most consistent for me. All right, so let's get into this case. So as you can see by this x-ray, you don't have to be a doctor to see that there's something going on one side of this person's face. Pretty significant swelling. And this was, was probably taken during his maybe 5th or 6th day in his second hospital. And so let's go over how this case started. So this patient presents initial complaint to the dental office with a toothache. Little toothache, lower right tooth. Been hurting for, on and off for a couple of weeks. And now the last couple of days, it's gotten a little bit worse. No swelling, nothing like that. The dentist says, hey, let me put you on some antibiotics. And this was before I was involved in the case. So I don't exactly know what went on in their office, but basically the history is, here's some penicillin. So not amoxicillin or anything, but penicillin. So penicillin is generally given as either PenVK, which the normal dose is like 500 milligrams every 6 hours for, 7 days, so 28 tablets. Or amoxicillin people do, and most of the time people prescribe it as 500 milligrams 3 times a day. I actually prefer 4 times a day just because of the peak amount of amoxicillin in your system is about 1 to 2 hours after your dose. So if you're giving it every 8 hours, you're going to have kind of a pretty good decline before it comes back up again. So I've generally been giving amoxicillin if I give it Q6 hours or every 6 hours. But anyways, he had penicillin, so probably PenVK, 500 milligram. Didn't get better. In fact, he was getting worse on the penicillin. Went back to the dentist. At this point, he had a little bit of swelling. Not a lot, just a little bit on the cheek. And he also had trismus. So what's that? Trismus is when you can't open your mouth very wide. Most people can open their mouth like 30, 40 millimeters. He probably couldn't go past 2 centimeters, so 20 millimeters or so, but not much swelling. So just now he has limited mouth opening, but there's still not a lot of swelling there. At this point, dentist said, I don't know what to do. Go to the ER. He doesn't say, hey, you need to see an oral surgeon or a periodontist or whatever. He just says, go to the ER. So the patient goes to a local ER, and they end up admitting him. At that point in the ER, he's getting a little bit more swollen. And this is within a day, okay? The ER put him on Unison, which is a broad spectrum, pretty common antibiotic in the ER. It's usually like 3 grams every 6 hours of IV Unison. They admitted him. So he sat in the hospital for 3 days on Unison IV and continued to get worse. What I mean by worse, significant cheek swelling, couldn't open his mouth. It's getting kind of farther and farther up the face, believe it or not. This hospital, realizing they don't have any surgical backup, there's no dentist there, there's no oral surgeons, they end up transferring to a bigger hospital. He goes to a bigger hospital, gets admitted through the ER and directly admitted to the hospitalist service, and they end up consulting. And so, when I see the patient at this point, he's pretty significantly swollen, still has significant trismus, can't open his mouth at all. At this point in time, he's already has infectious disease following him. They switched his antibiotics from Unison to a high-dose ertropenem, basically antibiotic IV. And they also got him a PICC line, which is a long-form IV that he can keep in for a number of weeks. That's more stable than just a peripheral IV, or standard peripheral IV, I should say. And they consulted me, oral surgery. So I saw the patient, and you can see at this point, this is his x-ray. Pretty significant buccal swelling. Also, it's a strange infection because not only is it in the cheek area or the buccal area, it's now tracking up the temporal spaces. It's in the side of his head. It's on the side of his orbit, and it's involving both eyelids.
To look in the light there. Yeah, it's a little tense up there, huh?
At this point. And this is from a lower molar. And so it's not a normal progression. I've seen a lot of infections over the years, and this is not a normal progression. It's concerning at this point. And so remember, he had a little bit of swelling, actually had no swelling, just some pain. And then he had just trismus after 3 more days of antibiotics, no real swelling. Then he had significant swelling all of a sudden started happening, after all that. And so they consulted me. I scheduled him for the operating room. We took him to the operating room. I drained the cheek abscess. I was able to get some bad teeth out at the same time. And I put a drain in the inside of the cheek, or a buccal space, drain through the buccinator muscle. And he was in the hospital for 7 more days after that on IV antibiotics, just slowly kind of turning the corner and getting better. Again, he had the PICC line placed so he can have his IV at home when he's discharged as well. And you can see here the drain in the buccal space. And this is another video here that I'm going to show you where I'm actually kind of examining his face, and I'll show you his eye. This is just before I took him to the operating room. You can see how significant the swelling is around the eye already. And there have been reports of swelling getting into the orbital space through the superior orbital fissure or the inferior orbital fissure, essentially, and causing cavernous sinus issues, vision issues, muscle issues with the orbit, obviously brain issues at that point. But you can see here on post-op day 21, so 3 weeks after I operated on him, he's already discharged from the hospital. He's still giving himself IV antibiotics through a PICC line at that point. And the only thing left really on his face is that little seroma under his eye. And I was able to just quickly lance that and get some of that serous fluid out of there for him. It wasn't an infection. It was just some residual tissue from all that swelling he had that just collected there for a while. So that was pretty simple. But that was, 3 weeks after surgery that he finally was really pretty much almost back to normal. So I think I was able to track this infection. So I just thought it was really interesting. So I tried to track how this progressed. So it started from a lower molar, okay? It got to the masseteric space. That's an internal space. You don't really see swelling there, but the internal swelling caused the trismus. So because of involving the masseteric space, he wasn't able to open his mouth, but there wasn't any sort of swelling on the face or inside the mouth that we could see. So when the dentist saw him and said, "Hey, you're not opening your mouth at all. I'm not sure you're getting worse. Just go to the ER." That's essentially what was happening there. From that space, the masseteric space, it also contains the internal maxillary artery, and it borders the lateral pharyngeal space and the temporal spaces. The lateral pharyngeal space is the one where read about these infections where it spreads. You can compress your airway, so it has potential to go down that way, but it didn't. It went up. So it actually borders the temporal space, and that's where it went. So the side of the face, the side of the head, the side of the orbit, that's ended up where it went. And then from there, from the temporal space, that's where he had the pain. He had swelling over the ear, the orbit, the eyelids, and so forth. From here, if you let it progress, it could potentially go through the superior orbital fissure and cause, the eye to bulge out, or proptosis. You can cause optic nerve issues like neuritis or abscess palsy, where you can't, turn your eyeball to the side, basically. Yeah, I just thought this was a very interesting progression. It's not a normal progression for a dental infection. The good things about this was, when the dentist recognized that the low dose penicillin or whatever wasn't working, even though there wasn't a lot of swelling, the patient could not open his mouth at that point. It's just said, "Hey, go to the ER." Unfortunately, he went to a community ER where there's no coverage. There's no dental coverage there. And most ERs actually don't have dental coverage or oral surgery coverage, believe it or not. So they just put him on IV antibiotics, didn't get better, and ended up transferring to a different center, and that's where they consulted. And so the principles of infection generally are, incision and drainage and IV antibiotics, and most people will turn the corner, but also recognizing what's happening. So if this had potentially gone further in the orbit and caused proptosis, that could increase your pressure, and you can perform an emergency procedure. I've only done this once, and I did it in residency, where you can do a lateral canthotomy and just basically clip that little tendon here, relieve that pressure, and kind of decompress the orbit. I didn't have to do that. I didn't get that far, but you can see from the video how close it was getting there. So I just thought this was a very interesting case. Just one more caveat about antibiotics. Like I said, if I do amoxicillin for a routine infection with minimal swelling, when you prescribe these medications, or if you're taking them, if you're not seeing any sort of decrease in your symptoms within 1 to 3 days, I would even wait 3 days, you need to let your provider know, or if you're the doctor, you need to follow up with this patient. Don't just give it to him on a Thursday and you're off Friday, Saturday, Sunday, and before you know it, this patient's in the ER. Follow up when you see these people, just because if it's already swollen, you got to make sure it's staying there or getting better, and it's not spreading like something like this. And so that was one thing, recognize the trismus, sent him to the ER. So those are all, interesting things I just wanted to mention. But I hope you got something out of this case. I just kind of a nerd and just tracked where the bacteria went. But thankfully, everything worked out great in the end. People were on it. It didn't let it get to be a permanent issue for this patient. So hope you guys enjoyed it.